Thank you. I'd like to open it up the floor for questions, comments. Andres?
Yeah, I had a question. If you could talk a little bit about bullying or cyberbullying, the online, telecommunications and all this as a means that might facilitate eventually these outcomes. If you could just mention a little bit about that, please.
The question has to do with bullying and cyberbullying, and I can address the question relative to what we know about risk for suicide. What we don't have any data, we don't have any studies yet on the effectiveness of bullying prevention programs and suicide rates. The reality is there is a significant risk of increased suicide ideation and suicide attempt for those being bullied, those who are bullies, and those who are bullied. That is, those who became bullies because they had been bullied. And that last group actually has the greatest risk for suicide of the three groups. So we know that there is a significant association between suicidal behaviors, ideation, and attempt. We have no data with regard to death by suicide and bullying. There are a great number of bullying prevention programs, and clearly we would like over time to demonstrate that they have some impact. But of course we'd have to, as a denominator in any equation, we'd have to know about all those young people who've been bullied relative to those who've been bullied and who otherwise would have been suicidal, and that data is going to be extraordinarily hard to gather. That said, clearly it is a significant risk factor, particularly among young people. The more difficult question has to do with cyberbullying, and to date I've not seen any dramatic evidence about prevention programming relative to cyberbullying. I think it's probably a much more difficult beast to get one's brain and hands around, but an appropriate focus, no doubt.
Jim and then Bridget.
That was great, Lanny. I was wondering just about blister packs. What's the objection? Just the cost, the blister pack approach to, and what's the rationale for the industry not wanting to implement blister packs?
Jim, I'm not sure I know the answer to the question. My initial understanding, like everything else, is cost. And of course, the more pills you sell, the more money you make. So the blister packs mean fewer pills per box, bottle, or whatever, or a much greater cost in terms of packaging. I think that more likely than not is the explanation that makes sense. Again, there are so many medications that one would have to deal with relative to overdose potential, and so many manufacturers of those medications, particularly now with generics, as well as the original manufacturer. It's going to take a great deal of advocacy over time, and I don't know that anybody's really leading that effort to date.
Thank you very much for your presentation. I found it very thought-provoking, and the emphasis on the reduction in means, I think it made some very well-taken points. But I found myself thinking back on the comments that Kevin Hines shared with us at lunch, and two things came to my mind. One is he said he Googled about suicide and was pointed to the bridge, and then also that it would have made a difference to him if someone had said, how are you doing? How can I help? And then I thought back to one of our prior workshops, looking at information technology, and we heard a bit about what the suicide helpline was doing so that when people do search for means of suicide, they get directed to the suicide hotline, and that when people on Facebook see someone that they care about talking about things that concern them about death, they can actually connect that person to a suicide counselor. I was thinking about impulsivity, I was thinking about youth, other ways of outreach, and I was just wondering if you could comment on your thoughts about the balance between looking at removal of means to bolstering those other elements in our society that might prevent someone from seeking out the means because they got the services they needed or got connected.
I try to make the point right up front that suicide is the outcome of a lot of bad things going on at once. And in that sense, intervention and prevention requires not a simple approach or a single approach, but approach it perhaps any point in the complex developmental pathway, if there's such a thing. Crisis centers are important. Helplines are important in the overall suicide prevention effort. And we have some good data, primarily Maddie Gould studies out of Columbia, relative to people who do call being helped. The problem, of course, is that it requires the outreach of the individual in trouble to make the call. One has to engage help-seeking behavior. And those who are most at risk for suicide are also least likely to seek help. And that's a conundrum we've yet to solve. So that males, for example, don't call helplines to any degree the way females call helplines. And so there is a fair degree of attention now and some movement toward looking at outreach in the other direction. So instead of waiting for the person at risk to reach out, those of us in position to know that someone's at risk, making the outreach to that individual. So there's a lot more effort, for example, on continuity of care approaches after hospitalization, psychiatric hospitalization. The risk of suicide in the next 30 days after being hospitalized and as a psychiatric inpatient is in the range of a 300-fold increase relative to the next year, which is still increased by some 60 or 70-fold. So we know that improving our access to people who've been hospitalized because of suicide risk and making sure that they continue to get care and that there are efforts to engage them are more effective. There are studies out of the States, out of Australia, out of the UK that have engaged things as simple as sending a postcard to somebody who has been in inpatient treatment and sending that postcard with some frequency, simply communicating, we care about you, please get in touch with us if there's any problem, we're still interested in how you're doing. Nothing much more than that. And they've been able to demonstrate reduced frequency of ER admissions for suicide attempts among those people who had come through the ER for suicide attempts, so reduced repetition of attempt. The great problem we have in engaging people at risk is one, finding them, and two, recognizing that those most at risk are not help seekers. And there is painfully little research being done worldwide on methods to increase help seeking among, in the Western world, psychiatrically disturbed males, in low middle income countries, people who are more likely to be impulsive, et cetera. We haven't solved that problem yet. I'm a clinician by training, so I'm not an epidemiologist, I'm not a public health specialist. I think I speak a little bit of your language, but my language primarily is when you come to my office, I know what to do. And I can help you if you get to me. The problem is most clinicians worldwide are terribly undertrained in terms of knowing how to assess someone at risk appropriately, no less than how to create preventive interventions over time in a therapeutic office. So we have a great deal to do on that level, even when we find these people, getting them into treatment and then treating them effectively, because we first, when they come into our office, need to assess them reasonably to know that they are at risk for suicide in order to appropriately intervene. So, you know, I recently retired, but I think I've got about 100 years worth of work left in front of me.
Yes, thanks so much, Lanny. This is just a great presentation. I don't know enough about pesticides, and the methodology that I'm hearing, and it came through a couple of times today, was to reduce the access at all, meaning you can't get the pesticide. You use alternative methods for what you want to do for pest control. Is that the only way to manage that chemical injury that results in suicide? Or are there ways to change the composition of the pesticide that when initially ingested, there is an immediate emetic quality or there's some bittering agent, it's much like antifreeze with dogs, where it's not sweetened anymore, and the dogs don't lap it up like they have and died. Is there some way that has been changing that product so that we reduce the it's not the access, but reduce the actual lethality, if you will, of the chemical injury?
There have been, over the last 5 years, I'm guessing, pilot studies in Sri Lanka, India, and China, sponsored by the World Health Organization, the International Association for Suicide Prevention, and Syngenta, maker of pesticides, which is extraordinary. And the approaches in those pilot studies have been to recognize that rural farms need pesticides. And absent federal legislation to reduce toxicity, the approach has been to, in pilot studies, to provide these farmers with lock boxes. So pesticides are no longer kept as, if you notice that slide, they were on a table. Now they're in a locked box, 2 keys, one the farmer, the other another family member. So if the farmer's wife is pissed off at her husband for whatever just happened and is intent on finding that bottle of pesticide, she's got to get a key from him. And hopefully he's not going to give it to her. Messaging on the box with regard to, don't do this, get help. And in at least one study, there has been an immediate availability of a antiemetic that could be used at the time of an ingestion, knowing that we can't get these people to an emergency room fast enough. So the initial data, these are small studies, but the initial data looks very promising. But there are problems, and as with any pilot study, it's going to lead to 5 more studies before we have a solution. One of the problems is that keys get lost. The boxes sometimes deteriorate. One of the studies has now created a box in the ground rather than on the wall, so that, it is like a tomb where pesticides can be kept. So looking at the quality of the control, a lot of work yet to be done, but there is at least some, to date, industry-supported effort to look at not removing pesticides, but simply making them more difficult to get to.
Any other questions or comments? Are you good? Okay, thank you.